All right, in this audio lecture, we're going to be covering cardiomyopathies. So cardiomyopathy is a disorder of the heart that affects the myocardium. Okay. So we have a weakened myocardium, and we get enlargement of the heart. So here's a normal heart. Here are the various types of cardiomyopathies, right? So we have dilated cardiomyopathy, hypertrophic cardiomyopathy, or restrictive cardiomyopathy. And so generally, we're going to see a weakening of the myocardial wall here. So this is the thickest layer of the heart. Okay. We'll see weakening of that, or we will see dilated ventricles, meaning they've gotten larger. Okay. What we have here is we have a myocardium that doesn't work as effectively as it does normally. So the first type of cardiomyopathy that we're going to cover is dilated cardiomyopathy. Okay. This is the most common type of cardiomyopathies. So this is the kind that you see most often. And so as a indication, we're going to look for cardiomegaly as an option. So cardiomegaly is enlargement of the heart, and it's enlarging likely due to the decreased myocardial contractile strength. And so here we get blood pooling in this ventricle, expanding the left ventricle, and so it makes the ventricle larger, right? The muscles sometimes hypertrophy, right? So hypertrophy is a response that we see in response to increased use or increased cell demand. In dilated cardiomyopathy specifically, we're going to be talking about ventricular dilation, right? So this is talking about enlargement of the ventricle. Okay. And in this condition, like I've stated before, is that we have damage to the myocardial fibers, and so they don't work as effectively as they once did. Okay. So what happens is this affects cardiac output. So by decreasing the stroke volume, so the amount that we're pumping out of the ventricle, okay, so we're decreasing stroke volume, you're decreasing cardiac output, and this is the category where this disorder falls. It falls into disorders that decrease cardiac output. And so since our stroke volume is decreasing, and maybe some blood over here in this region over here doesn't get quite squished out, it stays in there. And stagnant blood clots, right? So then you get the potential for clot formation in the ventricles, right? These clots can end up forming embolisms that travel through the circulatory system and cause other negative effects. So we see cardiac myopathy occur more frequently with age, so with increasing age. It occurs more frequently in African American men, and it's oftentimes unknown cause, right? So we see age, ethnicity, and then we see unknown causes here. Secondary causes for cardiomyopathies can include chemotherapy, because chemotherapy, you have chemicals that are circulating through your body that are killing all cells that they encounter. They do target highly mitotically active cells, but that doesn't mean that they don't get some other cells in the process. Alcoholism, cocaine abuse, pregnancy, infections. We see secondary causes also include thyroid toxicosis, so increased levels of thyroid hormone, diabetes mellitus, neuromuscular diseases, hypertension, coronary artery disease, hypersensitivity to medications. So these conditions right here, with the exception of neuromuscular diseases, are going to increase demand of the heart. And so when the myocardium starts to fail, we start to see this cardiomyopathy develop. So in thyroid toxicosis, you're going to increase cardiac work through excessive thyroid hormone, driving up metabolism. Heart rate has to match metabolism, otherwise metabolism cannot continue increasing. Right? So we're increasing ATP demand and oxygen demand as a process. Coronary artery disease, because in this condition we are decreasing blood flow due to this disease. So coronary artery disease, we're going to talk about in disorders that affect the periphery. And so we'll see that coronary artery disease is highly associated with heart health, and we see heart health really fluctuate with this situation. What are the manifestations of dilated cardiomyopathy? Insidious onset, so the generally manifestations pop up really out of nowhere. We see dyspnea, fatigue, angina. So dyspnea and fatigue are just general manifestations of disorders that decrease cardiac output. Angina is going to be a product of essentially a heart attack. So this is pain in your chest due to a decreased delivery of oxygen to your cardiac tissue. Activity intolerance, because now your myocardium is not going to pump blood and your cardiac output is decreasing. And so this kind of goes hand in hand with fatigue. And then we start to see individuals start breathing faster, okay, tachypnea. And why would we be breathing faster? Well, we would be breathing faster because we are pumping less oxygen to our body, right? And so we need to increase the amount of oxygen loaded into our blood. And this is generally this is my big indication here: jugular vein distension. This is because the blood starts to back up, right? And then because your myocardium's pumping less, now that blood pressure starts to back up, okay, causing a resistance, increased resistance over here with the jugular vein, draining back into the superior vena cava. And it seems like this individual's probably had a heart surgery at some point because he's got a scar right there. So you can find a full list on page 86. There's several other manifestations that can be included in here. Always be looking for the general manifestations of disorders that decrease cardiac output. Yeah. The next topic we're going to cover is diagnosing dilated cardiomyopathy. First and foremost, you're going to use some standard lab tests, echocardiogram and electrocardiogram. Right? The ECG is going to tell you about electrical disturbances. Remember that we have conduction tracts where electrical signals are transmitted throughout the body or throughout the heart. Echocardiogram uses sonar technology to allow us to visualize the heart, see if it's beating okay. We might do a chest x-ray. Chest x-ray is just going to give us a static view of the heart, okay, whereas an echocardiogram is going to give us a moving picture of the heart. Heart catheterization, so this is when they can enter the heart and figure out what is wrong via inserting a catheter through a vein, generally in your leg or your arm, okay, and then going through the heart and finding this area where you're experiencing cardiomyopathy. Or they could use nuclear studies. So this is looking at radioisotopes and tracking through the body. What is the treatment for cardiomyopathy? Decreased cardiac demand. This is going to be the main thing. You might use pharmacological agents in this process, or you might use lifestyle modifications, or both. Right? So pharmacological agents might include beta blockers, ACE inhibitors, which are angiotensin-converting enzyme inhibitors, or calcium channel blockers. So the heart is dependent on extracellular calcium for contraction. And if you block those calcium channels, you reduce the available calcium. Lifestyle modifications: stop smoking, decrease drinking, eating healthy is always going to help. Getting some aerobic activity like walking. You may not actually be able to run or exercise fully, but some activity is better than nothing, unless that activity is going to further worsen the problem. We could use an implantable cardiac defibrillator. So this is if your heart develops an arrhythmia, or dysrhythmia, or arrhythmia, and we need to reset the natural rhythm of the heart. Okay? And this is something that you would walk around with, and they insert it and they attach it to your thoracic cavity. We could use cardioversion, and so in cardioversion, this is using the paddle, so defibrillation. This is the same technology that is used right here, but on a much larger scale. So defibrillation is used on the skin, and it stimulates the heart and the rest of your body in that area. through electrical signals. Last case scenario, heart transplants, but we know of all kind of the problems with rejection and then how that leads to an compromised immune system. The next type of cardiomyopathy is hypertrophic cardiomyopathy, and what we see here, so what we saw with dilated cardiomyopathy was something that affects only systolic function. Here we actually see this disorder affects diastolic and systolic function, and notice the thickness of the interventricular septum and the myocardial walls. So diastolic filling is going to be compromised because you have less room to fill up the ventricle with blood. Okay. As you contract, this interventricular septum, because it's so big, starts to impede flow. So we see that diastolic and systolic function are both affected. This is more common in men than women, and those who are sedentary versus those who are active. We see things that increase your risk of developing this: hypertension. So if your ventricles naturally have to work harder to overcome the afterload that is placed on your ventricle, then we could get thickening of the ventricular walls or hypertrophy, right? And this hypertrophy, I guess, to some extent, is going to impair myocardial infarction. Now, if we have valvular obstruction disease, so maybe we have infective endocarditis, okay, this is going to be infection of the endocardium again. We have bacterial plaques forming on these valves, obstructing flow. And so stenosis of the valve, or if we have stenosis of the aorta up here, this could also lead to this hypertrophy of the myocardium. And then we could also have thyroid disease. But what is that ends up happening in this disorder is that the ventricular wall stops being able, it's too stiff and it is unable to relax. So you can't fill it properly because it doesn't relax. You can't generate a strong contraction, really. So we see systolic and diastolic function both affected. So if the ventricular wall is stiff, how is this going to affect end diastolic function? So this is end diastolic volume. This is the volume at the end of diastole. What is diastole? That is ventricular relaxation. Okay. So we would expect end diastolic volume to decrease because the ventricular walls don't relax. They don't go back to their normal shape. Okay. This is going to end up reducing stroke volume and ultimately reducing cardiac output. So the manifestations are very similar to dilated cardiomyopathy. We're not going to expand on them too much. We diagnose it similar to cardiomyopathy, that dilated cardiomyopathy. So treating cardiomyopathy is the idea here is you want to change things that are going to increase diastolic volume and remove the backup of pressure that has been inserted in the right side of the heart and the left side of the heart. Okay? So the first task is going to be reducing the ventricular thickness. Okay, so this can be done through several different mechanisms, but what we want to do is we want to relax this ventricular myocardium, and we might do this through pharmacological means. We might use surgical techniques, right? And so all this is in an effort to increase cardiac output, increase end diastolic volume. Okay? And so by surgical opportunities or applications, I'm talking about actually removing some of the myocardium to reduce the thickness of the ventricular wall. This would improve stroke volume, this would improve cardiac output, and all the while increasing end diastolic volume. Pharmacological agents that you could use to increase cardiac work might include beta blockers or calcium channel blockers, ACE inhibitors, right? So if we are decreasing the demands on the heart, then you are essentially improving cardiac function. On to our last cardiomyopathy here. is going to be restrictive cardiomyopathy, and this is going to be the least common cardiomyopathy that you actually see. It's going to be common in other parts of the world, not really here, so South and Central America, India, Asia, and Africa. So we have rigidity of the ventricles that leads to this dysfunction, right? And it leads to diastolic function. So the first cardiomyopathy was dilated cardiomyopathy, and that affected systolic function. Okay. Hypertrophic cardiomyopathy affected diastolic and systolic function. And then now we have restrictive cardiomyopathy that only affects ventricular film. So what causes restrictive cardiomyopathy? This can be caused by amyloidosis, and what amyloidosis is we get fat deposits in the myocardium, affecting contraction and function of the myocardium. Hemochromatosis is going to be iron in the cardiac tissue specifically. Radiation exposure to the chest, so if you get an X-ray or some other kind of radiation exposure to your chest, it could mutate the cells, the DNA, causing irregular protein production. Connective tissue disorders like Marfan syndrome could result in restrictive cardiomyopathy. Now, Marfan syndrome doesn't, I don't think restrictive cardiomyopathy is on the manifestations or the complications of Marfan syndrome, but it is a connective tissue disorder that deals with elastin production. Myocardial infarction, so if you get a decrease in blood flow to the heart, okay, this is going to affect function. Sarcoidosis, okay, is going to include cell growths that are just kind of irregular and they're occurring on various organs. And cardiac neoplasms would be benign and malignant neoplasms. I think generally these are benign neoplasms for the most part. So what are the manifestations of restrictive cardiomyopathy? Now, generally, this restrictive cardiomyopathy is going to exhibit a lot of the same manifestations that we saw with dilated cardiomyopathy and disorders that decrease cardiac output like fatigue, dyspnea. We saw angina with dilated cardiomyopathy and jugular vein distension, right? So now the pressure is building up and the venous blood cannot return to the heart unimpeded. So how do you diagnose restrictive cardiomyopathy? It's going to be very similar to dilated cardiomyopathy. How do you treat it? You treat the underlying cause, whether it's amyloidosis, which I don't think there's much of a treatment for that. If it's a dysrhythmia, you're going to treat the dysrhythmia. And if it's heart failure, you're going to start interventions to relieve the work on the heart. The ultimate product of this is that you really may need a heart if you have restrictive cardiomyopathy. It can't really be surgically repaired. It's going to be pharmacologically and then lifestyle decisions. So, but the prognosis generally with restrictive cardiomyopathy is generally pretty poor. And this is primarily due to the heart failure, which we haven't discussed yet, but we will get some introduction to that in another audio lecture. All right, until next time.